Good morning, everyone. Today I will presenting a case study analysis of a patient who is 60 years old, female, and presented to the emergency department with acute pulmonary edema and secondary to fluid overload on a background of congestive cardiac failure and chronic renal impairment. So, in this presentation, I will mainly talking about the patient's high priority clinical manifestations, the underlying pathophysiology and the interaction between her multiple disease conditions and the evidence-based management plans. So, for the case overview, we can see she presents going to the ED at 3 o'clock with worsening shortness of breath over 2 days, sudden onset chest pain, productive cough, and nocturnal dyspnea. Her past history included heart failure with reduced ejection fraction, cardiomyopathies, chronic renal impairment, type 2 diabetes, and completely heart block and the permanent pacemaker insertions. On arrival, she appeared critically unwell with a severity respiratory distress, a hypotension, diaphoresis, and alert mental status. Investigation showed pulmonary fluid overload, cardiomegaly, and severe renal impairment, electrolyte abnormalities, and left bundle branch block. Uh, And the final diagnosis was acute pulmonary edema, secondary to fluid overload on the background of a congestive heart failure and a chronic kidney disease. So according to the ESC heart failure guideline, uh, acute pulmonary edema is a medical emergency associated with high mortality, if not rapidly recognized and managed. So in the part one, I will mainly mention about patients his A2E and primary service finding. Using the primary survey approach, several high priority clinical manifestations justify pseudomedical. Starting with the airway was patent. However, her decreased GCS and confusion increased the risk of airway compromise if deterioration continued. Breathing was the most critical concern for these cases. She has a respiratory rate of 38, oxygen saturation of 86% on room air. This feel critical inability to speak full sentences and require 15 liters of oxygen via non-rebreather mask. This breathing strongly indicates the acute pulmonary edema and severe impairment of gas exchange. Circulation was also unstable. She was hypotensive with a blood pressure of 88 over 62 and a tachycardia at 113 beats per minute. So, additionally, signs in these included diaphoresis, cold fibrosis, raised JVP bilateral edema, and pansystolic murmur. So these findings suggest reduced cardiac output and systematic congestions. Under disability assessment, her GCS has dropped from the baseline, and she was deterred, disorientated to time, place, and person, indicating possible cerebral hypoperfusion and hypoxemia. Finally, exposure findings include inability to mobilize independently, low-grade fever, and severe peripheral edema. Overall, these abnormalities indicate multi-system deterioration with risk of respiratory failure and cardiogenic shock. Therefore, escalation to medical was clinically appropriate. Uh, in this part, I will mainly talking about the pulmonary edema pathology. So this slide demonstrates the pathophysiology of acute pulmonary edema. This patient she had a cardiomyopathy of an ejection fraction of only 29%, which just indicates she has a severe systolic dysfunction. Because the left ventricular was unable to pump effectively, cardiac output decreased, and this caused increased for left ventricular and the diastolic pressure, which was transmitted backwards into the left atrium and the pulmonary circulation. As pulmonary capillary hydrostatic pressure increased, fluid leaked from the pulmonary capillaries into the interstitials and the alveolar spaces. This results in edema. Uh, Clinically can explain by patient may have some uh, diffuse cracks, tachypneas, orthopnea, or hypoxemias, and also severe respiratory distress. And also the chest X-ray finding of pulmonary congestion and cardiomegaly support this pathophysiological process. So according to heart failure guideline, pulmonary edema occurs when elevated left side cardiac pressures exceeding lymphatic and drainage capacities, leading to alveolar flooding and impaired gas exchange. So this slide will explain the cardiorenal syndromes contributing to this patient deterioration. So she had a severe renal impairment with with an EGFR was 15, and because the kidney could not effectively excrete sodium and water, fluid always accumulated within the intravascular and the interstitial compartments. So this will increase the preload and worsen heart failure. As the cardiac function deteriorates further, renal perfusion also declines and causing worsening kidney injury. So this vicious cycle is also known as a cardiorenal syndrome. So clinically can explain by pulmonary congestion, raised JVP, and bilateral pitting or edemas, or fluid overload, or hyponatremia, or hyperglycemias. So her hyperglycemias was especially concerning because the renal dysfunctions combined with structural heart disease significantly increase arrhythmias risk. Study also showed that heart failure and CKD commonly coexist and amplify each other's progression and mortality risk. So for this patient, uh, she has many disease and between each others. So her clinical presentation results from multiple chronic disease, and also they are interacting together. Firstly, she has a heart failure caused the reduced cardiac output and neural hormone activation. So activation of the sympathetic nervous system and the ROS systems initially compensates for poor perfusion. However, over time, it will causes like vasoconstriction, sodium retention, fluid overload, and also worsening for ventricular stress. And secondly, she has a CKD. So CKD also worsen fluid retention and electrolyte imbalance. Thirdly, she has type 2 diabetes. Like type 2 diabetes likely to contribute to vascular dysfunction and the progression of renal disease. Her condition abnormalities, including complete heart block history and left bundle branch block, also reduce cardiac work efficiencies. So, finally, she has a conduction disease, which is LBBB. LBBB causes ventricular uh, dyssynchrony, which further decreases pumping effectiveness in heart failure patients. Finally, echocardiography demonstrates severe mitral regurgitation. The regurgitation blood flow increased the left arterial pressure and pulmonary venous congestion, worsening pulmonary edema. In a nutshell, her deterioration was not caused by one single disease, but rather by the combined effect of heart failure, renal impairment, diabetes, and the conduction abnormalities. And this flow chart will mainly summarize the overall deterioration process. So chronic disease cause reduced cardiac output and the activate compensatory neural hormone pathway, including the sympathetic nervous system and ROS. These mechanisms cause fluid retention and vasoconstrictions. As fluid accumulated, pulmonary edema and systematic congestion develop. This then will cause a hypoxia and hypotension, reduce oxygen delivery and organ perfusion, subsequently result in confusion, worsening renal functions, and the systematic deterioration. Finally, the patient will become critically unstable and may need a medical activate. So this case highlights how deterioration in acute heart failure is also a multi-system issue and rapidly progressive. So, finally, I will mainly talking about the immediate manage plan and immediate priority for RN to take care of this patient. So management my priority should also begin with airway and the breathing support. The patient should be positioned upright in high follow positions to improve lung expansion and reduce venous return. High flow oxygen therapy should be continued with continuous monitoring of oxygen saturation and the work of breathing because she had a severe pulmonary edema and respiratory distress. Preparation for non-invasive ventilation like NIV, such like CPAP or BPAP, will be appropriate if her condition goes worst. And NIV can improve oxygenation and reduce preload in acute cardiogenic pulmonary edema. So for circulation management, continuous cardiac monitoring and frequent blood pressure assessment are also important as well. And I think the med team should monitor closely for signs of cardiogenic shock, including worsening hypotension, reduced urine output, coprofibrillary, and the decreased consciousness. Street fluid bands also monitor is also essential due to her fluid overload and the renal impairment situation at this time. Uh, so the ongoing management should be focused on his renal function as well. I think repeat blood tests should be assessed his potassium, sodium, creatine, urea, and acid-base status. Hyperkalemia requires urgent escalation because it may trigger life-threatening or arrhythmias. And neurological observation, including like GCS, should continue regular because altered mental status may indicate worsening hypoxia or reduced cerebral perfusions. Escalate a daily weight or edema assessment and JVP monitoring will also help to evaluate the patient current fluid status. And escalating on higher acuity such as HTU, CCU, or ICU may be required depending on patient response to treatment. Effective ISPA communication will also be between nurse staff and the med team is essential to rapid intervention and continuity for the care plan. So, so finally, for about the major nursing priority in this case, including improving oxygenation, reducing cardiac workload, monitoring for arrhythmias, maintaining tissue perfusions, and identify deteriorations early. Acute pulmonary edema can deteriorate rapidly, therefore frequent assessment is essential. Early escalation significantly improves patient outcomes because delayed recognition of deterioration is associated with increased mortality in acute heart failure patients. So this case not only demonstrates the critical role nursing play in the recognition, but also say about the importance of escalation and evidence-based management of the deteriorating patients. So, finally, in conclusion, This patient experienced acute demonstrate heart failure complicated by pulmonary edema and chronic renal impairment. Her severe respiratory distress, hypotension, fluid overload, and alerted mental status justify urgent medical activations. The interactions between heart failure, renal dysfunction, neural hormone compensation created progressive multi-system deterioration. So early recognizations, comprehensive assessment, and evidence-based intervention are essential to stabilize patients with acute pulmonary edema and reduce mortality risk. And this is my reference. This is page 1, and this is for page 2. And thank you for your listening. That's it.